So there is a long tradition of pancreatic study in Verona for sure, and I am from Verona. Let me say you welcome to Verona first. Ductal adenocarcinoma, detection and staging. In my talk, I will speak about detection, speaking about imaging, obviously, and then I will introduce the entity of very small ductal adenocarcinoma. This is very important for improve the survival if we are able to detect this lesion, because not always, but if it's small, we can think that the lesion is resectable. So we will speak about the resectable ductal adenocarcinoma. Not always the two entities are together. Small means not the same of resectable. Then I will present a typical presentation or complicated presentation of ductal adenocarcinoma. It is so difficult sometimes to diagnose correctly. Then staging and guidelines. And also flowchart, local flowchart. I think it is important because we obtain a local flowchart in Veneto for the management of ductal adenocarcinoma. Just to introduce the problem, this is a consensus, multi-center consensus, where you can find that in presence of a solid mass suspicious for malignancy was reached this consensus that biopsy proved is not always required. So we can directly send the patient to the surgeon. And this is so important because the suspicious is very often, if we are speaking about a small lesion, is very often only radiological. So we are, this is our task. It's not so easy sometimes. So I want to be sure, I need to touch with my eyes that the lesion is really present and it is really a ductal adenocarcinoma. So I can ask the name, sometimes it's easy. I have the name of this lesion, you can find a double duct sign, you can see infiltration, or unfortunately everything in the retroperitoneum here, and the lesion also is typically hypovascular, we know, so the diagnosis is so easy. The sensitivity and specificity is so high, up to 100%, so no literature here because are really huge, you know. So this is our technical setting for CT. Speaking about CT, the detection back to black means that we want to detect the lesion hypo, and we can diagnose and detect the ductal adenocarcinoma in this case. NCCN, we have the guidelines, we can follow the guidelines. In suspicion of clinical mass, we can use CT. Please, short note to say that some authors suggest also the use of the late phase because the retention of contrast in this lesion, because of the high desmoplastic reaction, we can detect the lesion hyperdense in the late phase. This could sometimes improve the detection of small ductal adenocarcinoma. Unfortunately, are there some limits? Yes. In small lesion, small means we can speak about lesion less than 2 cm, so very small. And this is a paper where you can find that a lot of ductal adenocarcinoma were detected in not conclusive CT. This is, you can see there are, however, no image in the study. So we are radiologists. I'm not happy to read these results without any cases, without any image. So the limits, what about the limits? You can see small ductal adenocarcinoma here, very near to the duodenum. So sometimes this area is so difficult for the detection, and also the isthmum, the neck of the pancreas can be difficult for the detection, also because this area is difficult for the resection, is so important for the resection. And so in this case you have a very small ductal adenocarcinoma that unfortunately is isodense, but you can find easily detect the secondary sign, dilation of the main pancreatic duct. And this lesion was sent, this patient was sent to the CT from a simple ultrasound examination. Look how it's easy to detect these lesions. So few words on ultrasound. I want to say that very often it's so easy to detect the lesion percutaneously or endoscopically, and so we know the lesion is visible, the lesion was hypovascular, even if isodense. So we can improve the detection, and you can see trusting ultrasound, performing MRI, the lesion was perfectly inside the pancreas, so small ductal carcinoma. So this is an important study in my opinion because the lesion is smaller. The lesions are smaller, less than 1.5, and if you see the final results of these huge data coming from multi-center study, half of the lesion, solid lesion in the pancreas less than 1.5 are malignant. So we need to improve our detection. And we know from literature that sometimes the small ductal carcinoma are isodense. This is due to the fact that the fibrosis is not compact, is not so, therefore, hypovascular the lesion, because there are not enough fibrosis inside the lesion. And this is also important. This is also secondary signs are present in only in larger lesions. So we can not always solve the problem by using the secondary sign. This is another paper where endoscopic ultrasound find a lot of lesion again. The mean diameter is 2 cm again, so very small lesion, not detected, not completely well detected on CT. This is an example, but the lesion is completely invisible here. We have dilation of duct, and the lesion is here detected by means of diffusion weighted imaging. And this is unfortunately due to the fact that was stented, there is endoprothesis inside, so never perform CT and MR after the catheter, the endoprothesis, the stent in the biliary tree. Few words on ultrasound means that at the beginning we can use elastography. This is a new technique on ultrasound, able to tell us that the lesion is stiff. So this is an incidentally detected lesion. It is absolutely stiff by means of elastography. And in our department, we have a lot of lesions coming from ultrasound, and also in Italy, I have to say, ultrasound is the first imaging modality. So to improve the first line, we can have a better diagnosis. Only one slide to say you that we can also inject contrast. Is not present in all the countries, but we can have the injection, and this is a small lesion in the usinate process of the pancreas, results to be hypovascular, hypoechoic. It was a ductal carcinoma at the end. Sorry, this is a comparison of contrast ultrasound results and CT on characterization of ductal carcinoma, 133 cases. And you can see the small one, we are speaking about less than 2 cm lesion. We have no false negative results of contrast ultrasound, but unfortunately not always the pancreas is well visible by using US, we know. We can improve the detection, changing KV. Yes, this is a well-known study. We can use this technique to improve the conspicuity of a ductal carcinoma for sure. But let me show you this case. Is a young lady, 29 years old. There is a mass in the body of the pancreas, well detected by means of ultrasound in this case, no vessels and hypovascular. We move to MR directly. And so MR can be a solution for a small lesion, and you can see the slightly hypo-intense lesion on T1, T2, the lesion is hypo, and then there is a retention of contrast accumulation because of fibrosis. This was unfortunately a ductal carcinoma in a very young patient. I need, a shelter, yes. I need to solve the problem of small lesion, and we can use directly MR. This can be a solution. This is an example how looks we know the ductal carcinoma very small, hypo on T1 facet. This is the most important sequence with no contrast, and then after contrast, the lesion is markedly hypo. So dilation of duct always, but also please consider to look and to perform, and then to look at diffusion weighted imaging. The conspicuity on CT comes from the compact fibrosis, but we have compact fibrosis in the larger lesion. When the lesion is very small, we have only cells, and so in a small lesion, MR can be a solution. Let me show this case. We have dilation of duct, no clear sign of lesion, but when we move to MR, it's so easy by using diffuse fluid imaging. So the detection is improved from this paper. Staging can be, however, well performed, local staging. We will speak about the liver. And then in this paper, diffuse fluid imaging should be routinely included. We know, look, the dimension 3 cm is not really, from a pathological point of view, a small ductal adenocarcinoma. Once again, this is the lesion that I showed you before. So in our Veneto in Italy flowchart, we introduced the use of MR directly after the detection of a small lesion less than 2 cm on ultrasound. So to avoid a double examination, to avoid a possible false negative result of CT. What about the staging? It's easy to be sure about the resectability, but to be sure that the lesion is really resectable, I want to detect a small lesion is a matter of time for sure. So if the lesion is isodense, this is another case, please consider once again the use of MR. Do you have the double duct sign in this case? The lesion is slightly hypo on T1, but not well visible on T2. But again, we have a restriction or diffusion with imaging. So in this case, the lesion, only a stricture of the duct, no dilation upstream. The lesion is invisible on CT. And we move to MR, so difficult to detect, but there is a restriction. And this was the lesion that I showed you before. Only cells, few fibrosis, very small ductal adenocarcinoma, T1 and 0, M0, perfectly inside the body of the pancreas. Once again, where is the lesion here? We have the secondary sign that is not this duct, but is this duct that is too enlarged in the tail of the pancreas. And the lesion, where is the lesion? Not so easy to detect. And even with an enhanced MR, we can detect the lesion here, hypo on T1, slight dilation of duct, and restriction, very small T1 and 0 M0 ductal adenocarcinoma again. What about the staging? We have to come back to CT because with one examination we can stage the liver, we can stage the lung. And so the relationship with vessels are well presented by NCCN guidelines. And unfortunately, I am not so accurate with CT in the resectable situation. So my accuracy improved by moving from the resectable to unresectable one. So the numbers of CT, the accuracy of CT is absolutely higher in unresectable tumor. What about the involvement of the vein and the artery, even if less than 180 degree, is not the same for some authors. So we can think about a better prognosis if the vein is involved and not the artery. So look, in this case, this is important to have a distinction in between these two conditions of infiltration or local infiltration. So we can use the angles, yes, for sure, but borderline resectable is not only an anatomical concept. So in this case, we have to discuss, we know, in a multidisciplinary meeting, the situation of the patient. So time perhaps will change. We have a resectable lesion, and in this case, we have an infiltration of superior mesenteric artery. We can fill the template for sure. We need to cover everything. And please do not conclude, do not report the lesion is resectable. This is not our task. We have to describe the situation and discuss in a multidisciplinary meeting what to do. Also because, also in our institute, we are conducting a study, a research on the use of chemotherapy in resectable pancreatic ductal adenocarcinoma to improve the R0 results at the resection. So resectable, this is a resectable tumor. Yes, completely, perfectly inside the body of the pancreas. You see the periphery of the pancreas is not involved. This is a smaller lesion, but there is an infiltration of the retroperitoneal fat. Coming to the liver, staging is so important that the adenocarcinoma to be sure that the liver is cleaned by metastasis, and unfortunately here also because of dilation of duct of the biliary tree, lesions were not detected. With a simple diffusion weighted imaging, you can see the lesion, and now I show you here. So MR, the superiority MR for the liver staging is well known. Unfortunately, there is also a period after which there are no correlation with surgical theater results. So this is 25 days, and this is really a problem because we have to perform MR examination for the patient before these 25 days before the resection in every patient. And this is our results. We do the same study, and unfortunately 20 days again changed significantly the correlation with the surgical results. Two last cases just to show you that sometimes ductal carcinoma infiltrating the duct can present with acute pancreatitis. This again, we are in the worst situation for the detection. Here there is a fluid collection, fluid spread around the pancreas. The lesion is absolutely not visible, and also an MR, T2, and diffusion not visible. The lesion, however, is hypointense here, very small, was confirmed to be a visible endoscopic ultrasound, was confirmed to be a ductal carcinoma. So, 2 words on differential diagnosis. We need, after the detection, we can have the differential diagnosis of endocrine tumor because of the margins, but the dimensions sometimes, but what is very important, the vascularization, we know. So hypovascular ductal carcinoma, hypervascular, the endocrine tumor, but sometimes we can have a small lesion, hypovascular endocrine tumor due to fibrosis with a double last sign presentation, hypo on T1 fat, and also hypovascular, so very similar to ductal adenocarcinoma. In conclusion, detection, CT, but please consider MR to be sure to improve your capability, your detection of ductal carcinoma, very small, especially less than 2 cm. And also ultrasound, generally speaking, percutaneously or endoscopically performed, may play a role. Small ductal carcinoma, gold standard, MR, that's the reason why in our flowchart in Veneto again, we insert MR after the detection of small ductal carcinoma less than 2 cm. Small is not the same or resectable. Staging CT reporting template is the gold standard, is the must. And to consider resectable a lesion, we have to be sure about the situation on the liver. Thank you.